Thank you. So we will have the second session about the placenta accreta spectrum disorder will be sent diagnosis and therapy, and of course for the high risk pregnancy, especially for the placental problem. And the second one is the Dr. Alvaro Jose Nieto Calvache. He's from Fundación Philadelphia, Colombia, and he have high interest in the placenta accreta spectrum, and he already published a lot of publication for this area. So not wasting any more time. So the time is yours, Dr. Amar.
Rosie, thank you very much for the kind introduction. Let me share my screen. Can you see my screen at all?
Yes, we can see that
Okay.
clearly.
First of all, thank you to ISUOG and Fetal Medicine Foundation for this kind introduction to talk about ultrasound diagnosis of placenta accreta spectrum. So now what I've done is I've taken the liberty to change the topic a little bit from ultrasound diagnosis of placenta accreta spectrum to ultrasound assessment of suspected placenta accreta spectrum, because we don't know at the end of the day till we open up whether it's really placenta accreta spectrum or not. The second point I wanted to make is that we have got to identify what is the exact condition that we are screening or looking for. And some years ago, we made this a case for what is called as clinically significant placenta accreta spectrum. So what does that mean? It means that the condition should prove difficult access to the baby, in the sense that it should be anterior placenta previa, so that getting access to the baby is not easy. Placenta comes first before the baby. The second thing is difficulty in definitive treatment. And the point I'm trying to make is that if it is a fundal accreta, it doesn't really interest me. What does interest me is that accreta in the lower part near the cervix, where definitive treatment is not only difficult, but it is associated with a lot of morbidity. And earlier studies, publications tell us that many of these women have injury to internal organs, injury to bladder and bowel and things like that. And that's because of people trying to control bleeding coming from nearer the cervix. And lastly, we are interested in cases which are associated with increased maternal morbidity. The point here is that we are not interested in diagnosis of histopathology, which is an incidental finding. We are not competing with histopathologists. We are trying to look for cases which matter, and the cases which matter are those which are associated with increased maternal morbidity. So then, who are we going to screen? Which are these cases? And the risk factors I've put in over here, these are quite well known. But the point I wanted to make was the extent of the increase in the risk. And the extent of increase in the risk is with placenta previa. You see the extent of increase is 200 times higher. With previous uterine surgeries, about 20 times higher. So these are the ones which are most associated. And now everybody kind of realizes that most placenta previa or placenta accreta cases happen in a combination of placenta previa and a previous uterine surgery. And this is a publication, it's quite old, but I like it very much. Placenta accreta occurred in approximately 4 out of 10,000 women without placenta previa, but 10% of women with placenta previa. Now, when we are dealing with a combination of placenta previa and a previous uterine surgery or cesarean section, what proportion of them will have accreta? And if you look at meta-analysis and systematic reviews, we come up with various numbers. So I think that a screening study is likely to give us the correct answer. And this is something that we published quite recently. Nearly 60,000 women underwent ultrasound screening for placenta previa, and out of them, 220 had placenta previa, giving us a prevalence of 4 in 1,000. And that agrees with previous studies of placenta previa. 4 in 1,000 is a known prevalence of placenta previa. Now, of these, 75 had previous uterine surgery and 22 cases of accreta. So that gives us a prevalence of about 30%. And I believe that about 30% of all cases in a combination of placenta previa and accreta, placenta previa and previous cesarean sections will have placenta, clinically significant placenta accreta spectrum. Now, what about ultrasound signs? And there are several ultrasound signs which have been described with placenta accreta spectrum, and I've divided them into two groups. One is a remodeling of the uterus, and that is thinning of the low uterine segment, presence of lacunae, presence of feeder vessels, and increase in the placental thickness in the low uterine segment. The other group is abnormal or increased vascularity, so presence of bridging vessels and parametrial vascularity. So quite recently, we looked at uh, uh, agreement between different operators about these ultrasound signs. And the exercise was quite humbling. This is sent for publication, not yet published, but the exercise was quite humbling. I used to think that we are very good in ultrasound identification of accreta spectrum, but what we did find was that we are not good as we think we are. So two observers, one of them was myself, and the other one was Professor Eric Genu, who's a world authority on accreta spectrum. We looked at ultrasound signs, and it turns out that we don't always agree. So the agreement is only moderate. The second thing that we realized that the two important signs that we most agree on is presence of lacunae and increase in the vascularity. So that is quite important to remember. And this is Arthur Hertig, who is a gynepathologist who came up with this nomenclature of uh, degree of invasion, accreta, increta, and percreta. The point I wanted to make is that in a setting of previous cesarean section and placenta previa, all that you get is this variety. Because the lower segment is already thinned, there's hardly any endometrium or rather myometrium remaining. A lot of it is already scar tissue. So you don't get such big myometrial thickness here in a case of previous cesarean section anyway. And it doesn't take very much for the villi to come from here till here. So that's why it is quite important to realize that the morbidity is more because of partly because of the remodeling which happens because of previous cesarean section. Now this is a clip of known placenta accreta spectrum, and this is a black and white image, a clip which shows you several things. One is that it is a central previa, so implantation must have happened lower down in the cervix. The second thing that you realize is that there are lots of lacunae. Third thing you realize is that the placenta is quite thick, and that happens because of the abnormal implantation in the first place. So these are signs that can be seen even without the use of color, and one should be able to identify that. The second thing is increased vascularity, and several people have asked me, what do you mean by increased vascularity? But you look at vascularity, something like this, and you don't have to be objective in that case. It's important to realize that imaging in placenta accreta spectrum goes beyond identification and diagnosis, but it's also really important for planning of the treatment. So placenta and the uterus are three-dimensional structures. It is difficult to get spatial orientation with still images. And for that reason, I would highly recommend that surgeons should attend ultrasound scan for them to realize where the placenta is, topographic of that placenta, so that can help the surgery in a big way. Now, just as surgeons should attend ultrasound scans, I would highly recommend the ultrasound or sonographers to go to operating theater and see for themselves what they thought, whether that is really the case. And that's the only way we can learn. So preoperative imaging, it is a good idea to do it in theater, and that decides what the abdominal entry is going to be, what the uterine entry is going to be, and for help for delivery of the baby. So you know where the baby's head is, where the bottom is. So that helps us, or the surgeon rather, in order to deliver this baby. So what are the principles that I've learned? First is prenatal diagnosis is not absolute, and false positives and false negatives do happen. The second thing is placental invasion in surrounding organs has never been shown. It is not a problem with trophoblast, and there's been lots of publications showing that trophoblast of accreta and trophoblast of normal pregnancy is identical. The problem is not trophoblast, problem is implantation, area of the implantation. So it's not a cancer, it does not go into organs. Significant new vessel formation is very common, and that's really important to realize that. And there are abundant collaterals in the pelvis. So the traditional blood supply is modified in cases of placenta accreta spectrum. And lastly, failing to plan is a good plan to fail at surgery. So at the end, I would like you to leave with certain points. The first point is the interest is clinically significant accreta spectrum. Ultrasound assessment is not diagnostic. The verdict should be low or high probability of accreta spectrum on ultrasound. Ultrasound is valuable beyond diagnosis. It is very useful for surgical planning as well. The most reproducible signs that correlate with histopathology and morbidity are lacunae and increased vascularity. And it's really important to realize that morbidity remains high even with low probability of accreta spectrum. So one must not feel that just because you can't see ultrasound signs, it still remains major previa and a previous cesarean, one or more principles or points. I thank you very much for giving me a patient hearing. Thank you.
Okay, thank you. What a very interesting presentation. Now, for the next speaker is from Dr. Alvaro. You can start. The time is yours.
Okay, thank you so much. Good evening to all. It's a very big pleasure for me share this space with you. Rosie, can you see my screen?
Yes, we can see your screen clearly.
Okay. So as Ama has made very clear, the diagnosis of PAS need to be synchronized with the treatment, but it's very frequent that what we found in the operating room is different that the prenatal diagnosis images tell us. This is a case of false negative ultrasound for PAS, and you can see my friend Juan Manuel Burgos with his underwear full of blood at 9 p.m. thinking lovely in the sonographer that did not see the accreta in 9 ultrasound that this patient had. This case, of course, had inadequate initial surgical management by inexperienced personnel, and you can see at the right evidence of mesial bleeding and polytransfusion. But we forgot sometimes, especially the surgeons forgot, that even in expert hands and in hospital with all the resources, half of the cases of PAS are only detected during the laparotomy. Diagnose PAS is not easy, and most of the cases, the obstetrician not receive proper training during his residence program. Therefore, it's the obligation of every obstetrician to recognize accreta during a laparotomy and to be prepared for this diagnosis when managing a patient with risk factors, especially a placenta previa with a previous C-section. So surgery is the most important step in the diagnosis of PAS. Another very common situation is the false positive of the prenatal diagnosis for PAS, and we sometimes forget this. This is a patient taken to surgery suspecting PAS, but at the end, she has only a placenta previa, but she lost her uterus and he received a extensive median laparotomy with common internal artery balloons. Another very important situation is the presence of dehiscence. Recent work of Dr. Llanusa and Dr. Amarbid make it clear that many patients classified initially as PAS had at the end an uterine dehiscence. This patient is an example of that. This patient had a prenatal diagnosis of PAS, but you can see a very easy retrovesical dissection without any bleeding between the bladder and the uterus. At the end, after extracting the baby, the placenta burned without any problems and bleeding was not so high. This excellent paper showed that 1/3 of the patient taken to surgery suspecting PAS has at the end an uterine dehiscence. And even more interesting, when the ultrasound and the surgical image were reviewed by an external expert, diagnosed failure continued to be very frequent, with between a quarter and a third of patients being misdiagnosed. But the really important question is that if it's really necessary to differentiate uterine dehiscence from PAS. As you can see in the table, cases of non-PAS or uterine dehiscence have a very high associated morbidity with 2 liters of 2 units of red blood cells transfuses and 1.5 liters of bleeding, and with hysterectomy in a third of the cases. So what we do if there are prenatal image false positive or negative? So the first thing is that we must accept that. We must accept that it's very frequent to have this mistaken prenatal diagnosis, and every hospital with medium or high complexity obstetric care will face this situation. So we need to realize that and make that a good hospital preparation, and we recommend use telemedicine. And for false positive ultrasound result, we need also to realize that, and we need as surgeons to include confirmation of the diagnosis during the surgery and before applying potential morbid intervention. How can we do that? As we will see in the next slide, with intraoperative staging and individualize the treatment. The second point that I want to realize today is that the patient should be included in the process of planning their surgery. This very good paper from Brett Einerson makes it clear how patients and their families demand to be heard and consult about the type of management and that is proposed to them. They want to have option, even if hysterectomy is recommended, and including them in decision like the type of skin incision or the type of anesthesia will be a very good option. Okay, but if we have so many treatment options, hysterectomy, leaving the placenta in situ, or uterine sparing surgery, how can I choose one of these options should I train and which one should I apply to my patient? Well, the first thing is to make it clear that all past PAS expert groups must know and master all the management option, because as its name indicates, PAS is a spectrum of clinical presentation. So we need to offer enough treatment, but emphasizing safely, but without incurring in over-treatment. And other elements to take in account are saving resource, using the strategy with best possible clinical result for each case, and the expectation of each patient. And of course, the local available resource. How can I know if my patient, the patient that I am operating in this moment has a lesion limited to the upper part of the uterine segment, or had a very big lesion in the uterine affecting lateral and maybe posterior wall? The answer is intraoperative staging. So this is a simple and risk-free procedure that allows visualization the anterior and lateral wall of the uterus. Step 1 is opening the parametrial space, and step 2 and 3 focus on evaluate the anterior wall of the uterus. By defining which uterine wall is affected, the size of the lesion, and wherever the bladder can be dissected or not from the uterus, we can establish what type of PAS we have in front of us according to the topographic classification. This classification also takes account the location of the lesion above or below the peritoneal reflection, what arterial follicles are involved, and how difficult the surgery will be. So, how do we integrate all this concept to a management protocol? The first step is to ask ourselves if we have all the elements that we need to perform a PAS surgery in a safely way. If the response is not, even in a case with prenatal suspicion or an intraoperative diagnosis of PAS, if the response to this question is no, we need to defer the C-section if possible. We need to request all the local and even remote help through telehealth, but always think on defer the surgery if possible. So please always, if during a C-section, when you perform the laparotomy, you find this type of lesion, bulging with reddish or of lesion and hypervascularization in the anterior wall of the uterus, please stop and think and ask for help. In front and intraoperative finding of PAS, we must ask ourselves two questions. Is the mom bleeding, and should the baby be born now? As answer these two questions, you can have three options. The first option is that the baby is okay and the mom is not bleeding. So in this case, please defer the C-section, close the abdomen and refer the patient or wait for your colleagues at the next morning. The second situation is when the baby must be delivered immediately. In this situation, when the mom is not bleeding, you can extract the baby through the fundus of the uterus, close the abdomen, and defer the definite treatment of PAS. And the last and most serious situation is when the mom is bleeding. In this situation, the recommendation is extract the baby through the fundus and reassess the patient, because most of the cases after extract the baby, the bleeding reduce a lot of even disappear. And if that happens, you can act as a situation 2. But if bleeding continue, you need to continue the surgery. But remember, your hospital need to be prepared, and please use telehealth and support from staff in the additional people in the same hospital. Okay, but if we have the needed elements to do a surgery for PAS, we apply intraoperative staging with the 3 questions and the 3 procedures previously described. And with that, we can choose a type of lesion in the topographic classification. And this is a very good thing, because most of the cases you will find a lesion in the upper part of the segmentos or maybe adhesions. And in these cases, the surgery is not so difficult. But in all the cases, you need to ask 3 questions. It is possible to separate the bladder from the uterus. It is at least 2 centimeters of healthy myometrium below the PAS lesion. And it is more than 50% of the uterine circumference with healthy myometrium. If the response is yes, as in 80% of the cases, you can do a uterine sparing surgery. But you always need to looking for severe case, a lateral lesion or difficult retrovesical dissection. In this case, please don't try to do a conservative surgery and apply a specific intervention. Okay, and here comes a very important concept. As Amar said, surgery make it possible to accurately define the degree of the uterine involvement and choose the type of treatment. Ultrasound evaluations should attempt to locate the lesion in the uterus. It's not only the ultrasound diagnosis is not only for say yes or not for PAS. As sonographer, you need to give information, additional information to the surgery team. This is a diagram that we use in my institution every time we do an ultrasound or an MRI. The sonographer or the radiologist plot his finding in a three-plane diagram, and you can see how this imaging, for example, in a sagittal plane, correlates very well with the ultrasound images and with the analysis for the for the pathology. And this coronal plane is very similar to the anterior aspect of the uterus and the end of the surgery. The fourth point that I need to realize is the importance of the briefing. Always when we finish PAS surgery after 3 or 4 hours surgery, all the team want to go home quickly. But if we do the briefing at the end of the surgery, we can get better the work for future cases. And the last point that I want to discuss with you is the importance of learning from unfavorable or negative results. The literature is flooding with studies reporting good results, but management failure or adverse events are not usually reported, losing a unique opportunity to intervene and group that in that moment is sensitized after bad results. Analyzing 82 maternal deaths in lower middle income country, we found that all deaths were preventable, and the main factor associated with this death were inexperience of the treating personnel and inadequate surgical technique. So it is easy to propose that all patients are treated by experienced personnel, but we cannot ignore that training group are very few in the world. So what can I do? Our group has faced this problem in a low and middle income countries, and we have a very good result using telemedicine in Latin America and Indonesia. This is an example where hospitals that never before performed one-step conservative surgery were virtually accompanied by experts in other cities. You can see here our moderator, Rosie Arjananda, guiding the surgeon through a video call using only a smartphone with a reconstructed uterus after a focal segmental resection. And I want to share with you this experience from my hospital 2 weeks ago when we decided to use a double balloon catheter for the first time to treat a cesarean scar pregnancy. Being the first time that we use this technique, we contact Dr. Ilan Timor Trich in USA, and he immediately agreed to guide us through a simple video call. So a patient in Colombia was treated with the participation of the creator of the technique, connecting from the USA using only a low-cost telemedicine phone call. So this is the conclusion. False positive and negative diagnoses are very frequent. US ultrasound evaluation should include the topography of the lesion, and during laparotomy, the type of lesion must be confirmed before to apply potentially morbid intervention. All the obstetric service must be prepared for an expected PAS case. Please include telemedicine in your protocols. Patients should be included in the decision-making process. The teams, the PAS team must be trained in all available management options. Optimal treatment depends on each patient characteristic, and we need to remember that hysterectomy is not the only option. Thank you so much.
Thank you, Alvaro, Dr. Alvaro. Very interesting presentation. So we have several questions already. And first question is about maybe for Dr. Amar, the question about the ultrasound criteria for determine for the cervix invasion and the parametral invasion. Maybe you can give your opinion.
Thank you, Rosie, for that question. So cervical invasion is an important one. It's not really cervical, but it is in vascularity, assessment of vascularity. And if I can share my screen, I will show you what we mean by that. So vascularity assessment. So that is how we assess the vascularity. You see the bladder, you see the vascularity behind the bladder. but it's important to actually do this in a transvaginal scan. So here you see a transvaginal scan, you see the cervix, you see the vascularity, which is quite low near the cervix under the bladder. And this is going to be a difficult case. And the same case in a transverse section shows you the amount of vascularity there. So um, this is an important assessment, and what I showed during my talk was all abdominal scans, but this is a TV scan, and I firmly believe that TV scans are really, really important because that tells us the site where we are likely to encounter problems. So here, the vascularity is quite low down, and unless the separation of the bladder from the lower segment is easy, this case will be difficult. There is a potential for a lot of bleeding happening from low down, deep in the pelvis. So we should be prepared for this kind of problem, and it is only possible after we assess vascularity on TV scan. So it is not so much of invasion that we are looking at vascularity. So what happens actually is that the placenta doesn't actually go into the bladder. It is the anterior uterine wall is so thinned out that there is hardly any uterine wall between the placenta and the bladder, and there are lots of vessels, and that's what leads to problems. So if there is dense adhesions there, then separation of the bladder is not going to be possible. And Alvaro has shown you that a lot depends on whether or not bladder can be separated easily. If it can't be separated, then resection, primary resection, and repair is not going to be possible. This is where patient is going to go down the route of a hysterectomy.
Okay. Maybe correlate with other question about can we use the MRI to evaluate about the lower or the parametrial invasion more as like you mentioned.
Okay, so good question, really important question, and lots of people keep asking us, do we do MRI? Does MRI help with ultrasound scans? And there are pluses and minuses of MRI. So the positives about MRI is it gives us a very good idea about spatial orientation. Ultrasound is spatial orientation is not easily possible, especially for people who don't do ultrasounds themselves. So MRI gives us that. So that's an advantage. But it's important to remember that any technique is only as good as the person who's interpreting it. So not many people who are used to looking at accreta on MRI, and we get a fair amount of false positives. So in our practice, we don't use MRI for making a diagnosis. Ultrasound is good enough for us, but ultrasound is, rather MRI is good in terms of spatial orientation. If the surgeon is unable to attend ultrasound scans or is not sure, then MRI might be useful. So I think Alvaro uses MRI quite a lot. In my setting, we don't use MRI scans for making a diagnosis. Thank you.
Thank you. Uh, okay, there is another question. I think the important is how to bridging between the surgeon who did the surgery and the sonograph who did the ultrasound, where uh, sometimes the surgeon did not do the ultrasound, and sometimes the sonographer did not do the surgery. So maybe you can give any suggestion, and maybe Alvaro, how about your hospital? And
That is the situation in my hospital. In my hospital, we have a very good team, and the surgeons, we try to go to the ultrasound room every case, and we have as everybody have a chat in WhatsApp, and we put all the images from the surgery so my colleagues sonographers can see the surgery. But most of the hospital don't have so good communication between prenatal diagnosis team and surgery teams. So for that was the reason for doing the draft I saw you, because the ultrasonography is only understood by the person that do the study. You know, even after 1 or 2 months, when the same sonographer see the videos and the images, he don't understand what he reported in the first time. So the draft is very good for us. That is a very fast and useful form to remember the images, and for doing a topographic description of the lesion. Even more important than that, focus on if the case is a accreta or if the bladder is compromised, as Amara said before. We use that draft, but it's very important. It's the only way to improve the prenatal diagnosis sensitivity and specificity, that the people that do the prenatal diagnosis go to the operation room. Amar said that before, and it's very important for the surgeon team that go to the prenatal diagnosis room.
Okay, thank you. There is another question, maybe for Dr. Amar, who mentioned about the ultrasound. Is there any correlation between the uh, hypervascularity and the type of invasion? That's the first question. And the second question is about how to differentiate between the lacuna and the a normal placenta lacuna with the abnormal lacuna in the placenta accreta spectrum.
Thank you, Rosie. Thank you for the questions. So let's take the first one. You said about the vascularity and degree of invasion.
Yes.
Yeah. So I think as time goes, I'm increasingly coming away with this idea of degree of invasion, and the deeper invasion means severe disease. It doesn't work like that, because in any case, even in a case without previous cesarean section, the lower uterine segment is pretty thin, even normally. Now, in a case of previous cesarean section, it is even more common to see a very, very thin low uterine segment. So I don't believe that the risk correlate or degree of morbidity. What depends, what decides the morbidity is how deep, rather deep in the pelvis, or how close to the cervix the placenta is attached, and how much there is vascularity there is. So these are the two factors which determine the morbidity for the patient, as far as I'm concerned. So if you see a lot of vascularity, then yes, it is going to be a difficult one, unless the separation from the bladder is easy, and usually it isn't. When there is a lot of vascularity, there is problem there. If Alvaro wants to add anything, do you agree, Alvaro?
Yes. Usually we focus, as you said before, in the hypervascularity. So most of people still now thinking in placenta invasion. So as you say in your talk, that is not the situation. The placenta don't invade the uterus on the neighbor organs. So the problem during the surgery is a vascular problem. If you can't dissect the tissue and individualize the vessel, you can ligate all the vessels. If it don't matter if you have 100 vessels, if you can ligate each vessel, the surgery will have not a lot of blood, and you can do a safe surgery. So I agree with you, Amar.
Okay, thank you. And if the hypervascularity has happened not in the lower uterine segment, maybe from the fundal or posterior uterus, can we say that maybe it's correlated with the fundal invasion or the posterior invasion? Maybe, how about your opinion?
So
Yes,
go ahead, Amar.
Alvaro,
Go ahead.
go ahead. Okay, so again, an important question. I explained to you earlier on that what interests me is anterior low accreta. If it's fundus, then treatment is relatively easy. Getting to the baby is relatively easy. So one doesn't encounter the placenta before the baby is delivered. So baby safely delivered, then you see where the placenta is coming out. If it's coming out, clearly it's not the accreta. And if it is not coming out, then treatment is relatively easy. Nobody has major complications, even if it comes to a subtotal hysterectomy. But if a total hysterectomy is necessary because the invasion is in the lower part of the uterus, that's where complications happen. That's where injury to bladder, ureter, things like that will happen. Bleeding is so much more difficult to control. Fundus is easy, so it doesn't interest me as a clinician so much.
Yeah, okay. Thank you. Maybe Alvaro, you have
Sorry, yes, I agree with Amar because this is a very important topic. We need to forget that controversy about accreta, increta, percreta. You know, this is about a difficult surgery with a lot of blood at a risk of death for the patient. So you have the percreta with parametrial migration here, but at the extreme, deposit extreme, you have a placenta previa with hypervascularization. People with placenta previa can die if don't receive the proper treatment. So any patient with placenta previa, and even more patient with placenta previa and a previous C-section, have a lot of risk to major bleeding or even death. So as Amar said, you need to go surgery knowing that and be prepared for handle a difficult surgical case. Sometimes for the posterior PAS, you have a lot of diagnosis problem because it's not easy to diagnose posterior PAS with ultrasound. This is the more useful situation for MRI. But you need to be careful, do a very careful surgery. The first step of the intraoperative staging is the uterine exteriorization and the evaluation of the posterior wall of the uterus. So if you have any doubts about PAS in a posterior placenta, before trying to pull in the placenta after the baby extraction, you need to see the posterior wall of the uterus and after extracting the uterus and take all the necessary precaution to have the less blood you can.
maybe the last question. Maybe I think this is important for Alvaro. How about the uterine incision? How to open the uterus? Is it preferred from the fundal, transverse, or vertical? I think it is very important question. We have still 4 minutes left, so I think you can answer briefly.
Okay, that's a very good question, and this is part of a lot of question about specific technical issue. You know, the skin incision, the uterine incision, the closing uterine wall technique. I think the more important message I can give to our colleague here is that in placenta accreta spectrum is needed that you team train a lot. That this is, we have not a unique treatment protocol that apply to all the patients because you have a lot of different situations. For example, an accreta without placenta previa, you know, an accreta with the placenta in the fundus. So you can stroke the baby through the segmentus. But I think the only recommendation that all the surgeons agree is don't cut the placenta. Don't go through the placenta for extract the baby. Always avoid the placenta. So if you use the classical technique of cesarean hysterectomy, maybe you can recommend go through the fundus. But if you do an intraoperative staging and dissect the placenta and see that you can do a uterine sparing surgery, you can do an upper transverse segmental incision in the uterus. But it's very important to say that all the PAS team need to train a lot, need to share experience with another PAS team, because the most frequent situation is that a team in a hospital is only trying to doing the training curve by himself, but don't share their experience, their good and their bad experience with other hospitals. So if we go together, we can reach an objective faster. We cannot minimize the need to be trained a lot for do a very good surgery in PAS cases.
Okay, thank you. I think the time is already finished. Thank you for both of you for the very great presentation. Maybe we will continue for the session 3 about the ultrasound in labor and delivery. Will present by Dr. Tulioki, Dr. Ali Yosef, and Dr. Rasha Kamel. The time is yours. Thank you.